Good afternoon and happy Thursday. Thank you for joining us today for our webinar, Integrating Anal Health into HIV Prevention Strategies. My name is Nicole Elenoff, and I'm a manager on NASDAD's prevention team. And I'm joined by some incredible speakers who I will introduce to you momentarily. This webinar is scheduled to last for 1 hour, including time for a robust Q&A session. If you have joined us via GoToWebinar, you should see an introductory slide on your screen. If you do not see it, please use the chat feature to let us know. Please note that all of your lines will be muted to ensure good sound quality, and we will engage in a question and answer period at the end of the webinar. If you have questions throughout the session, please utilize the question feature located in the toolbar on your screen. This meeting will be recorded and made available to you at the end of the session and will be held on NASDAD's website. By the end of this webinar, participants will be able to discuss anal health's impact on sexual health and wellness, understand recommended anal screening protocols, and discuss anal health with clients and patients that identify as men who have sex with men, otherwise known as MSM. Our speakers today is Dr. Dimitri Daskalakis, Deputy Commissioner for the Division of Disease Control of the New York City Department of Health and Mental Hygiene. Welcome, Dr. Daskalakis. And we're also joined today by Daniel Downer, Executive Director of the Bros and Convo Initiative, a community organization in Orlando, Florida, promoting and protecting the health equity of Black, gay, bisexual, queer, and same-gender loving men. Thank you both for joining us today. I'm now going to hand off this presentation to Dr. D, who will get us started.
Great, thank you so much for having me. I'm excited to be a part of this this NASDAD webinar. Also, as a board member, it's great to see this topic and the great attendance that you're getting for this. So thank you so much. So I will dive in, and then my partner Daniel will close this off to give you a full view of strategies around anal health. Next slide, please. So just briefly, we're going to go through some of the really important pieces of anal health. The first and most fundamental is actually getting a thorough sexual history, then using that sexual history to guide appropriate STI screening, then really talking about the role of STI and risk for HIV, as well as PrEP and rectal STI screening. So really where the rubber hits the road in HIV prevention, using STIs as a way to guide some of the work that we're doing in prevention, then ultimately land on some really important topics around vaccination, since we have the power to prevent some very important diseases using vaccines that are readily available and approved. Next slide, please. So everything in it really begins with taking a thorough sexual history. So that means that it's a part of routine medical care. It's not something extra. It doesn't matter who the person is, no matter what their age, gender, who they have sex with, their ethnic background. It's critical for their wellness and overall health that we actually ask these questions. And the way to do it is to be non-judgmental. And again, make sure that all patients are asked this. It's a part of a regular history, part of a regular intake. So it's really important because it guides so much, including screening for STIs, frequency of screening for HIV, and then potentially counseling on practices to prevent STIs as well as unplanned pregnancy. It is important to remember that no one is immune from an STI if they're sexually active. So it's important to talk about sexual history in all patients. And though today we're focusing on men who have sex with men, heterosexual and married people, no matter what their gender is, should be asked about HIV and other STIs. There should be no assumptions made about sexual life based only on what someone's marital status or how they identify their sex lives. So it's important to ask all patients, and this is including individuals who have sex with with people of their own gender, or so lesbians, gay, bisexual men, and trans people. It's really important to ask about intentions to have children or avoid pregnancy. Again, not making assumptions about sexual life, but rather really using open-ended screening. Next slide, please. So there are 5 P's of sexual health, and I'll remind you of these. The first is partners. So it's important to ask about the number of partners, gender, and HIV status of partners over a given time. I'll add to that and say also, if you're asking about HIV status, to know about the care status of that partner, so you can engage the individual about PrEP or U is equal to U. Really important. Practices. So you have to ask to know. Types of sexual practices, you need to ask questions, be open-ended, but also not to be shy about asking questions to people. And that means being okay asking on their own terms. So are they having oral sex, anal sex, vaginal sex? Are they having front hole sex? Whatever the language necessary, you have to meet people where they are to be able to identify like what their actual risk is. Protection from STIs, like what do people actually do to prevent HIVs and STIs? So are they using barrier protections like condoms? Are they on PrEP? Do they know about PEP? Also important to get a past medical history that includes a view of STIs and HIV. So it's important to identify these for several reasons, because they are often biomarkers of risk for HIV and hepatitis. So just remember that in general, diagnoses of gonorrhea and early syphilis are signals of increased HIV risk among both men and women and should trigger routine offer of pre-exposure prophylaxis. So this is sort of where that rubber hits the road again, where having thoughts about STI and sexual history changes what we do to prevent HIV. And then again, no matter who they are, no matter what their gender, no matter what who they have sex with, important to ask folks about their desire for pregnancy and or use of prevention methods. Next slide, please. So one of the things we did in New York, realizing that this is just an example, that a lot of folks had problems identifying providers who were able to talk about sexual health, is that we created a list of providers in our jurisdiction that were good at talking to LGBTQAI individuals. We vetted them, we did a lot of work, and then we created a campaign called Bear It All that pretty much was if you can't talk to your doctor or medical provider, let's find you a new one. Folks can dial 311 and they can be referred to someone who has competency in these areas and could potentially be more communicative with patients if the patient wasn't feeling they got what they needed from their own physician or other healthcare provider. So this is an important problem and lots of solutions. And I think one of the most important is training. I think it's also critical from the public health perspective, given the stakes for HIV and other infections. Next slide, please. So in terms of screening, I think it's the CDC guidance for screening gay and bisexual men is excellent. So I won't go over this in a lot of detail for time, but there's a lot of things that we should do frequently. HIV is one, screening for hepatitis, but also important to think about 3-site screening for men who have sex with men. And that means a rectal test, a test that comes from the penis, and that could be urine or a swab. Most people prefer urine, and screening for gonorrhea of the throat. So when thinking about a full battery of sexually transmitted infection tests, I think I will convince you by the end of this talk that extragenital sites are of critical importance and the rectum is of very high importance. Next slide, please. And there's lots of reasons. This is a great CDC infographic that reminds you that that very often men who have sex with men are at higher risk for STIs in the throat and rectum, that they often have no symptoms. You will hear this over and over again in this talk. You can detect it by screening, and remember that these increase HIV risk. I will share data from New York City on that I think will be very convincing. In terms of looking at the extragenital site, again, 1 in 8 MSM screened for gonorrhea and chlamydia had it in their throat or rectum. So that's very frequent. And then also the corollary to that, the sort of flip side, is that 1/3 had not been screened even in the last year. And so that is a major issue and a major gap. So what should you do? So screening for STIs, including 3-site screening for MSM, is important. It should be done at least once per year. If individuals are more sexually active or have other risk factors, specifically drug use, or if they are on PrEP, you would consider screening them more frequently. And again, it says if indicated, but generally I think it's a good policy to think about 3-site screening for folks who are sexually active. In fact, it tends to be a good policy no matter MSM or not. If you use it for sex, you should probably screen it. Next slide, please. So I'll talk a little bit about some data for MSM around extragenital screening, and we'll go all around the US. So first in Baltimore, among men who had same-sex contact, only 10% of first STI testing episodes included extragenital sites. So you'll see why that's an issue. In a retrospective analysis in San Francisco of asymptomatic men who have had sex with men visiting their city clinic, what they found was that almost 84% of gonorrhea and chlamydia would have been missed if you only screened penis or urine alone. On the flip side, if you were only doing oral and rectal testing for STIs, you'd only miss 10% of STIs. So you should do all three, but clearly it shows the importance and value of the extragenital, oropharyngeal, throat, and anal testing. And then subsequently, in a multi-clinic HIV clinic study that was by the CDC, rectal chlamydia and gonorrhea annual screening rates range from 2.3 to 8.5%, despite the fact that there was a pretty high amount of positivity among asymptomatic folks. So that's 3 to almost 10%. Next slide, please. So one of the things that I think, at least in my practice and in our sexual health clinics in New York City, that has been really helpful is using self-collection. So I'll go a little bit over that data. So folks can swab themselves, and I will try to convince you that if you aren't convinced already that that works. In San Francisco, in their study, they evaluated self-collected penile and rectal swab specimens from men who have sex with men, and they compared it to how good the clinicians did. So they had some mixed results with the penile swab, but, and I'm not going to sort of read you all the details, ultimately, the sensitivities of the tests with self-collected and clinician-collected rectal swab specimens were comparable. So in other words, patients can do it. So self-collected rectal swabs from MSM are found to be a valid way for testing for gonorrhea and chlamydia, but you would probably prefer a urine versus a provider administered penile swab rather than self-collection of that. Next slide, please. In a UK study, very similarly, they compared nurse-taken versus patient-taken swabs. And again, they found something very similar, that men who have sex with men, at least in the study, can collect both rectal and pharyngeal swabs that are really comparable to those taken by a clinician. So at least for those two sites, folks can be trained to do this. And of course, London leading the way with some very innovative self-collection sites to be able to test for gonorrhea and chlamydia from all three sites. Next slide, please. Now, another really important thing to remember is the fact that many infections are asymptomatic. And it really raises the importance of just screening in general. So when you look at gonorrhea and chlamydia rectal infections, that purple color represents asymptomatic disease in men who have sex with men. So that pie is looking pretty asymptomatic for rectal infections for both of these bacteria. Urethral infections, gonorrhea looks to be more symptomatic, and chlamydia is, pretty much halfsy-halfsy. So I think it really raises the importance of extragenital screening as part of a recipe for good sexual health care. Next slide, please. Also, this is another way of looking at the data of what would happen depending on if you only did urine or urethral screening. So for instance, there was a patch of time in New York where sexual health clinics were only doing urine tests for men who have sex with men. Well, what that really means is that you would miss over 53% of chlamydia and over 64% of gonorrhea by not including those sites. So rectal infections would be missed. And I think, as we know, they do increase the risk for HIV transmission. So this is a critical gap that can be filled by making sure that screening is a part of what we do for both rectal and oropharyngeal, realizing that rectal infection could potentially increase risk for HIV. So in effect, STI testing and screening, attention to rectal STIs is directly HIV prevention. Next slide, please. So I'm going to talk a little bit about testing technologies. So first I'll say culture, that was the gold standard. Its sensitivity is not so great. So in some ways it can be like a coin toss. So if the test is about 50% sensitive, that means that you could guess as well as doing it. So it's not the best test for gonorrhea or chlamydia. Really, the way that folks are mainly diagnosing these infections are nucleic acid amplification tests, as well as some other versions of amplification. And then potentially there is not really a role for serology for rectal STI, gonorrhea, and chlamydia, but I just put it on there because some people do order it. Next slide, please. So briefly, nucleic acid amplification tests amplify and detect organism-specific parts of their genome, so either their DNA or RNA. So it used to be that that only urethral swabs were cleared, so I've got to update this slide. So now both urethral, rectal, and oropharyngeal swabs are possible, and its sensitivity is very, very, very high. Next slide, please. So I also want to talk briefly about symptomatic rectal infections and symptoms, because this comes up and is an important part of anal health. This is often called proctitis, and it's an inflammation of the rectum that causes discomfort, bleeding, and can cause a discharge of mucus or pus from the anus. So there's a lot of causes of proctitis, but they can be grouped broadly into 4 categories: autoimmune disease, non-sexually transmitted infections, harmful substances, and then finally sexually transmitted diseases or infections. Next slide, please. So proctitis, usually in the scenario of STIs, is common among those who engage in anal intercourse. STIs that can cause proctitis include gonorrhea, herpes, chlamydia, and a sort of super strain of chlamydia called Lymphogranuloma Venereum. Non-sexually transmitted infections causing proctitis are seen less often than STDs in proctitis. There's also the possibility of autoimmune proctitis that I talked about briefly. And so folks who have ulcerative colitis or Crohn's disease, that's inflammatory bowel disease, could present with proctitis. And important to remember that proctitis can also be caused by medications, radiotherapy, and also inserting harmful substances into the rectum. Next slide, please. So there is a whole spectrum of rectal infections. So it goes from very symptomatic to asymptomatic. There's a broad range. So it can present as bloody stools, constipation, rectal bleeding, discharge, pain or itching, or tenesmus, which means the feeling of having to defecate when you don't actually have to. What's also important is that proctitis can increase the risk for other chronic viral infections, including HIV, HBV, and hepatitis C. Next slide, please. So I like referring to this slide just to show how many causes can be identified, and the fact that sometimes you can't identify a cause for proctitis. So looking at a study from San Francisco, 101 men with clinical proctitis were evaluated. That means they all had symptoms. Most of them had white blood cells on smear, which means that someone took a swab and looked under the microscope to see if there were white blood cells, which is a marker of inflammation. 45% of people had nothing identified. And again, this is only men who have sex with men. So what you can see is that that although many didn't have a diagnosed cause, gonorrhea and chlamydia were heavily favored, whether it was alone or in combination. And just to prove the point that if you have one STI, you need to search for others. There were a fair number of folks who had, again, dual infections, and also syphilis. So important to remember that the screening of that testing a symptomatic person is important. And generally speaking, when you are testing someone with a symptomatic proctitis who is sexually active, you don't tend to wait for the diagnosis, but the assumption is that you treat for gonorrhea and chlamydia. It's important to also note that with that lymphogranuloma strain of chlamydia, you may need to treat longer. And so different guidance and guidelines exist in the world that if someone is symptomatic or presenting with rectal chlamydia, you may want to treat longer with doxycycline, but I won't go into that in a lot of detail. I just advise that you take a look at your at CDC and also local recommendations. Next slide, please. So just briefly, enorectal gonorrhea, again, usually acquired by anal intercourse, and I think I'm convincing you that it's usually asymptomatic. Symptoms are pretty much what proctitis can look like, so a really broad range from nothing to pretty severe rectal pain and soreness. Screening is critical, as I said, because of the fact that we don't catch it. We don't sort of see it as symptomatic all the time. So it depends on who they are, but somewhere between 3 months to annually is a great strategy for men who have sex with men. Next slide, please. Enorectal chlamydia, again, not that different, very similar symptoms. And again, screening can range anywhere from 3 to 12 months, depending on who your patient is. Next slide, please. And I do want to take a moment here to talk about Lymphogranuloma Venereum. So when I was an infectious disease fellow, this was a very rare phenomenon. And I remember, this is my story, I had a patient who had just returned from a part of the world that was seeing some increase in LGV. And he was in effect a case study in our clinic, because it was such a strange thing to see this out of certain parts of the world. But unfortunately, I think that there's a lot of data that LGV is pretty prevalent. I know in New York City, we have seen a pretty high prevalence of LGV among people with rectal chlamydia. And it's interesting that some of the outbreaks that have been reported included individuals who also had associated outbreaks of hepatitis C. So there's this new variant that's chlamydia L2B. There are other types of Lymphogranuloma Venereum variants as well. But ultimately, you can see that it's out there. It's been here longer than we think. And it tends to be symptomatic for most people, although we are absolutely seeing asymptomatic LGV as well. So it's important to think about this and to consider what your optimal treatment is for chlamydia in someone with rectal disease. Like I said, the treatment for regular chlamydia can be quick, just a couple of grams of azithromycin, but with Lymphogranuloma Venereum, usually treat with doxycycline, and you treat for much longer. Next slide, please. So another important piece of anal health is screening for anal dysplasia and cancer, and specifically guidance that I've seen revolves around people with HIV. So for all patients with HIV greater than 35 years old, the New York State guidelines say that regardless of HPV vaccine status, you should do some work to screen for anal cancer. So first is to inquire about anal symptoms. So really important to ask about those symptoms, because they are a guide to see if you have to do further work. Perform a visual inspection of the perianal region. That means examine the patient, and also make sure that you provide information about anal cancer screening and engage the patient in shared decision-making regarding screening. So that means that you should consider anal cytology prior to doing any sort of rectal exam, digital rectal exam of the anus. Next slide, please. If there are symptoms that are concerning, a digital rectal exam is necessary. And there are other things that you can do. Promote smoking cessation, because that's a risk factor for anal cancer. That's just good guidance in general for everyone, especially people living with HIV. And also for patients with HIV over 35 years old, perform annual digital anal rectal exam to screen for anal pathology. Evaluate the patient for signs and symptoms that suggest anal dysplasia, and consider referral to high-resolution endoscopy for any patient with that abnormal anal cytology. So no matter what the grade is, whether it's high or low, if the anal pap comes back positive, that means referral. So really important to remember that. Next slide, please. So I won't go over this in a lot of detail. Please look for your local guidance and CDC guidance around vaccination. Remember, HPV is an anti-cancer vaccine, so it's really important that folks are vaccinated. I'm not going to read this just for just for time, but ultimately, men who have sex with men, you should consider HPV vaccination, especially if they fall into the age ranges for catch-up. So it's really important to think about that, given that we can prevent anal cancer and in some cases, potentially also some forms of throat cancer. Next slide, please. So I also want to convince you that doing rectal screening is important as a biomarker for HIV exposure risk. So looking at our data in New York City, 1 in 42 men who have sex with men who come into our sexual health clinics end up being diagnosed within a year. That means that folks who are seeking sexual health care, you really need to put HIV prevention at the forefront because you can make a difference. Individuals who come to our clinics, men who have sex with men who get diagnosed with syphilis, had a 1 in 20 chance of being diagnosed with HIV within a year. And this is the one I want to highlight since this is what we're talking about today. 1 in 15 men who have sex with men diagnosed with anorectal STIs, chlamydia or gonorrhea, in our clinics were diagnosed with HIV within a year. We can interrupt that cycle by making sure that we link our sexual health encounters with HIV prevention. These are perfect patients for pre-exposure prophylaxis. Next slide, please. But I'll show you that even though we work really hard, we are really missing a lot of opportunities to prevent HIV using our gonorrhea and chlamydia infections among men who have sex with men in New York City. So these are some data from 2015 and 16. We will eventually redo this analysis, but the first one, the purple, represents HIV diagnosis rate among men per 100,000 population. So you can see which parts of our city have higher rates of HIV. Now, we did an interesting analysis where we estimated the difference in the number of observed and expected rectal gonorrhea and chlamydia infections. So the darker the color, the more gonorrhea and chlamydia we were probably missing. Well, that looks pretty much identical to me, with save a couple of areas. So we really have the opportunity, if we are doing better gonorrhea and chlamydia screening, that if we identify these infections in symptomatic or asymptomatic individuals, we could offer them pre-exposure prophylaxis and potentially prevent HIV acquisition. So again, really, for me, this was a very sort of eye-opening sort of modeling to sort of really look that even though we have a lot of screening of anal and oropharyngeal infections that are even in an environment where we do a lot of it, we are missing the boat a lot, and a lot of opportunities are being missed for HIV prevention. Next slide, please. I made it through, so I think I am going to hand the baton back. Thank you very much. And we're taking questions at the end, so we'll just keep going through.
Thank you so much, Dr. D, and really stressing why it's so important to integrate anal health care into HIV prevention work. Thank you so much. We're now going to hear from Daniel Downer from the Frozen Convo Initiative.
Thank you so much, Nicole, and thank you so much to my co-facilitator, Dr. Dimitri, for that amazing and informative part of the session. Before I move forward, I know that we're all adjusting to this new virtual life. And so please feel free, if you haven't hydrated yourself, to make sure that you hydrate, maybe do a little stretch up in the air or to the side, kind of get that blood flowing, just a little self-care check. If we are ready to go, we are going to move more into this portion of the session, which is really focused on engaging community members, particularly MSM, men who have sex with men, in their own anal health care. Next slide, please. Next slide, please. So I thought it would be great to create some baseline information or best practices for individuals when engaging with men who have sex with men in anal health care. I like to think of this as kind of like the base to a taco salad. So kind of whatever you use as your base for that, this would be. First thing is definitely to make sure that there are ethical boundaries that are set, friendly reminder around HIPAA, as well as no engagement during personal time and having strictly professional relationships. A lot of times the lines can get really blurred with community members, and particularly men who have sex with men. And so it's really great to already have those boundaries set, not only during the encounter, but after the encounter. Making sure that there's motivational interviewing and communication. So being mindful that we're communicating with understanding in a non-judgmental way, but also practicing active listening to really lean in and hear the questions, the concerns, and the comments that community members may have regarding their anal health. And then lastly, trust and rapport, making sure that with every encounter, it is a person-centered approach. Also being really understanding that there may be some possible challenges or barriers to engagement, and then also helping to identify and addressing those compounding barriers to care first before actually having the individuals engage in care. Next slide, please. So we've got a little bit of a case scenario, and you can feel free to provide your answers in the chat feature below in the box. So for our case scenario, we have Dante, who is a 26-year-old Black gay male that walks into your clinic. He moved to the area 6 months ago from Huntsville, Alabama. Dante tells you that he's concerned after experiencing anal creaming, which is kind of like a colloquial or slang term in the community, specifically the MSM community, to describe proctitis, which Dr. Dimitri had talked about previously. So he's telling you that he's concerned about experiencing anal creaming while bottoming, so being the receptive partner during the sexual encounter during his most recent hookup, in which he and his partner did not use condoms. Dante also admits to never having an STI screening and that he does not have insurance but is working part-time. So based on this information, I'd love to hear in the chat real rapidly and quickly, what would you do during this encounter with Dante? And while individuals are providing their feedback, we can move over onto the next slide, please. So I think it's really great to start off with try and learn. One thing that's really important, especially with speaking and engaging with MSM community members, is letting them know that effective anal health care is a two-way street. So the best way that they can care for themselves is to give themselves a little bit of prep work to see the results in improved healthcare and better health. And as we go deeper into the session, I'll be talking about some ways that medical providers can encourage MSM to be active participants in their own anal health wellness journey. Consider this kind of almost like a toolkit that's really great to maximize and optimize the time that you're spending in the encounters with community members. Next slide, please. So here are some things that you can encourage community members to do before their visit with you. These are some questions that they definitely should be asking and themselves, and that you can help them draft prior to the encounter. One, making sure that how do they plan to pay for the visit? Visits are very expensive and they're not free. And so it'd be really great for community members to be able to find out ways that they're intending to pay for the visit, whether that's through insurance, whether that's through a pay scale type plan, or whether that's through using programs such as the Ryan White HIV/AIDS program. What is it that they're wanting to get from the visit? Are there any specific anal health concerns that they may have? It's also good if they were able to have an understanding if they're currently on any, having any medical problems, or if they're on any medications, both prescribed and over the counter, including vitamins or supplements. And also if they're seeing other medical providers for anything outside of just their anal health care. Also great to know if your community members are currently sexually active, the number of individuals that are in their sexual networks, and whether they prefer utilizing condoms or not utilizing condoms at all. And lastly, if they're in need of antiretroviral therapy, PrEP, pre-exposure prophylaxis, or PEP, post-exposure prophylaxis. So these are some of the things that you can highly encourage your community members to kind of think of or to have written down in preparation for their visit with you or your clinical staff. Next slide, please. So here are some ways that you can encourage community members to make the most of their time during their medical encounters. Having questions specifically about their anal health concern. One in particular, which I'm so glad that Dr. Dimitri had brought up, was around proctitis or anal creaming. Specifically within the MSM community, there has been a lot of conversation around whether or not individuals are good bottoms or receptive partners or bad bottoms or receptive partners based on if they can actually anally cream, without understanding fully that anal creaming may be an indication that there might possibly be some possible STI transmission, or there might have been some possible trauma done to the anal cavity. Also making sure that during the encounter, community members can ask questions about any existing diagnoses. So not only specifically with their sexual health, but also outside of their sexual health. And then also any questions about prescriptions or treatments. Why in particularly do they need these services? Also testing for HIV and other sexually transmitted infections. It's really great to encourage community members, even if they are living with HIV, to really have a routine HIV and STI screening routine, as well as making sure that the screenings are specifically tailored to that individual based on the information that they're providing you during the medical encounter. And then also being able to answer maybe some of the questions they may have, specifically about how they might possibly be able to connect with the medical provider or clinical staff after the visit. Vaccinations also are a great talking point to have during the encounter, as well as additional services. So when community members come in during these encounters, they're bringing their whole selves, including maybe some of the challenges and barriers that they're currently experiencing. And in particular, when we look at MSM and Black and Brown MSM in particular, they are disproportionately affected by so many other challenges and barriers that are socioeconomic or socioculturally influenced. So being able to really create an opportunity for community members to let you know if they're in need of additional services, whether that's food, housing, transportation, or other community resources. Next slide, please. After. Here is how your community members can be their best caregiver after your visit. And I really highly encourage you or your clinical staff to share this with them, making sure that they actually are able to review how the visit went and how they felt about it. If they're specifically unsure about anything in particular, really making them feel comfortable about how they can express that, and then having a clear line of communication in which they're able to contact their provider. Really stressing the importance of following whatever instructions the provider or clinical staff have provided, but then also encouraging them not to keep that amazing, wonderful information that they might have learned during the encounter to themselves. So specifically bringing the nugget of wisdom, but keeping the names out of it. Also after, providing them information about vaccinations, as well as additional services that they may need to access or in the future or right now. And then lastly, being able to encourage them to establish a support system, which may or may not include you or your clinician staff, though it should. And then lastly, really educating, empowering them to have their own back. So these are some of the best practices that after you can encourage community members to do post their visit. Next slide. Lastly, I wanted to share some great resources for community stakeholders. That includes community members that you meet during your encounter, you yourself, medical providers, and clinician staffs. The first one is the Birds and the Bays, which is a really great resource that community members can utilize to kind of formulate some questions to make their appointment really, really super productive. A lot of times community members may or may not know where to start when asking questions, and it's really kind of sometimes uncomfortable being vulnerable and transparent about what's happening with you, both in and out of the bedroom with your medical provider. So the Birds and the Bays is a great resource. The second resource I encourage you to check out is His Health. His Health is an amazing platform resource created by NASTAD, and it's a product of collaboration among Black gay men, healthcare and service providers, public health professionals, federal health agencies, LGBT advocates, and community stakeholders. It's a really great dynamic training tool that provides continuing education courses led by experts, portraits of innovative models of care, and a plethora of evidence-based resources that will assist you in supporting the delivery of high-quality, culturally affirming healthcare services for Black men who have sex with men. And I would even say that could also be utilized for the broader MSM community. And then the third resource that I'd love to share with you all is Well-Versed. Well-Versed is, again, a tool created by NASTAD, and this is a really, really great community, I would say person-centered platform tool that really helps community stakeholders understand and educate and empower not only themselves, but community members on things they can do before, during, and after their medical encounters. So those are three great resources that I encourage, if you are not familiar with, to definitely get acquainted with. And that could also be tools that you share with your community members during the encounter, so that way they're able to make the most out of that. Next slide, please. And so I know that I breezed through that portion. So if there are any questions that individuals may have, we're going to move into the Q&A portion of the session. And myself or Dr. Dimitri be more than happy to answer questions that you may have. Next slide, please.
Thank you so much, Daniel, for sharing that really great presentation and for sharing different tips for providers to share with the community members that come in to seek services. We do have a couple of questions, and please feel free to add additional questions into the question box. Our first question is, if an organization is not implementing extragenital screening or 3-site screening, what's a good way to get started?
I'm sorry, this is Dimitri. My audio patched out for a second, so I only heard how to get started. I didn't hear the beginning of the question.
No
sorry
problem.
About that. I'm not sure it was even for me, but if you could repeat it, that would be great.
If an organization is not implementing extragenital screening, what's a good way to get started?
So I think it depends on what kind of organization. So I think if it's an organization that's able to collect lab tests, then I think it's trying to see if it's something that is a service that you can implement. If it's a medical organization, it's a lot simpler because I think it's just making sure that you talk to your laboratory to make sure that they're able to collect and accept these specimens. So now that these swabs are FDA approved for this purpose, like most labs should be able to do this. If you are an organization that does not have sort of the capability of being connected to a lab, I think it's probably worth reaching out to your local Department of Health to see sort of if they have any strategies for you in terms of how that can be set. I think that in general, if there are communities that you serve that are priority for HIV prevention, especially, it's worth reaching out to see if there's sort of some strategy for collection to happen, and then some other lab strategy if you yourself as an organization don't have a connected lab.
Thank you. Our next question is, it could be for both of you. Please clarify anal creaming. Is it anal discharge or anal lubrication? Is it discharge that is sometimes misinterpreted as lubrication?
Yeah, so I am going to let my great co-facilitator, Dr. Dimitri, start by answering more of like the scientific definition behind the anal creaming or
Sure.
and then after.
I think that it's about change. So I feel like there is some amount of secretion that's like going to be normal during anal sex. And I think that in my experience in patients who come and complain about this finding is that it's something that's different or new. And so I think that that's important to remember, that usually folks are complaining about a change. So like there could be some mucousy secretions that are normal during anal sex, and that's not something to be alarmed over. With that said, like if you have folks who are sexually active, like the trigger for treating someone for an STI or sending a diagnostic test should be very low no matter what. I think that covers the science part, Daniel.
Thank you so much. Yeah, I think it's important really to have a conversation with your community members. They know their bodies really, really well. And so if they are noticing that there is some mucus or secretion or discharge that's there that's not normally there, I think that's definitely grounds to have a deeper conversation, and if need be, take the precautions to identifying specifically what's happening with that. And also, I would say that I know that anal creaming is something, even though it's been happening for a while, it seems that it's like really kind of fairly new because there are a lot of conversations happening. So this is something that I think both community members as well as the medical community are learning together, which is equally exciting.
Thank you. This question, I think, is more for Dr. D. When implementing self-collection, what are some best practices?
This is a great question. I think really providing materials for coaching is actually really important. So I think there are. I think we have them available. I'm happy to sort of, if you throw me your email to see if we can send you what we've got. But we do have posters that are up in bathrooms to teach people how to collect. I mean, very often coaching is necessary. Some places actually even have like little videos to show people about how to do self-collection, especially oropharyngeal self-collection, and little animations for rectal. So I think that giving people guidance is really important, and not just giving them swabs and say, here, take them to the bathroom and do this yourself. If you don't have the visuals, I tend to give people the guidance for rectal self-collection, that I show them the swab, and I tell them that they have to actually insert the swab, and I try to make it at least understandable and say the goal is to hide the cotton part of the swab in the anus, and if possible to twirl it and then remove it and have it stay in for a few seconds. So I think that there's other ways to do it. A visual cue is much better than verbal communication. So I think that it's good to look at what's available. I can tell you We have it, and I'm happy to send it. The other place that has a great graphic for this is the Terence Higgins Trust from London. They have a really good graphic that I think is available online for rectal self-collection.
Thank you. Thank you so much, Dr. Dimitri. I am definitely going to reach out for those resources, and we'll include it in these follow-up materials.
Thank you.
Some additional questions. Should I be screening all MSMs, throat, urine, and anal for chlamydia, gonorrhea annually?
So that's a shared decision-making point. I think that, in general, like, I think that my sort of strategy is if you use it, you should screen it, is probably a good one, and a good sort of mantra for how to approach 3-site screening for men who have sex with men. I mean, there are definitely scenarios where people will decline doing certain tests, and they should have the right to decline it. I tend to offer 3-site screening to everyone. And if they say, well, I don't use this part of my body for sex, I then back off. So I think that the sort of system strategy is to make it the standard. But obviously, people are allowed to say, I don't need to do that because of X, Y, or Z. Now, if you disagree with that, it's worth having a conversation with them to say, well, actually, like, you have this risk and that risk. And so one really common thing is people who are inserted partners only will decline a rectal screen, and then sometimes you find out that they are doing other things. So potentially like rimming, which potentially it's lower risk, but could potentially transmit gonorrhea or chlamydia. So I think there's conversations to be had, and it really is about shared decision making.
And all of the same testing would apply for women who are having anal sex as well, right?
Yeah, I think the guidelines are like all over the place on this one, but I like our New York City strategy of if you use it, test it, I think is a really good one.
Fantastic. And I believe in that too. If you're using it, screen it. Absolutely. Are there any other questions that people would like to add? I don't see any at this point. And so, so for health departments that might be feeling a little hesitant about starting 3-site testing, what types of words of encouragement, besides of what you've shared today, would you share to them?
It's Dimitri again. I had that patch out problem. I missed I only heard share with them. I'm not sure if the question was for me. Could we try that again? Sorry about that.
Yeah, let's definitely try that again. So for, I know we already went over, if an organization is wanting to implement what would be a good first step, but what words of encouragement or advice would you lend to other health departments for getting into 3-site collection?
Yeah. So this is Dimitri. I think really, it's a priority. And so I think that is like my biggest word of advice, that, I think giving people sort of incomplete data around their sexual health because of limits that you have, I think is a really strong argument. I would say that using data for the folks who make policy, and also just reminding them about the clear national guidelines, I think is really critical in sort of setting up a program for screening. So I would say, use the data. I think the slide deck, I think that we presented, has a lot of good data. And I think if you visit CDC's guidelines, you're going to see that you're backed up. So I think use the data and use the guidelines to try to sort of change policy, and potentially also open doors to allow to sort of more complete screening for sexually active populations.
Thank you so much for that. And you're absolutely right that, this is a priority. I think another question just added in. Thank you so much. Our outreach mobile screening unit has been offering STI, oral, and anal screenings, but the information is great. Well, thank you so much. And maybe incorporating self-screening could be a future for the mobile unit. Well, thank you all so much for attending this afternoon's webinar on integrating anal health into HIV prevention strategies. This is definitely the first of many conversations to come. And again, the recording and supplemental materials will be sent out after the webinar. And for more questions, please contact myself, Nicole Elenoff, and elenoff@nastad.org. I'd like to thank Dr. Dimitri and Daniel again for sharing such great tips and wisdom with us, and for doing such great work in their local communities and abroad. And thank you all so much for the work that you're doing day to day. So this concludes our webinar today. I appreciate all of you, and I hope you have a great day and stay safe. Thank you so much.
Thank you.
Thank you.
Thank you.